Good morning, everyone. It is my distinct honor to welcome all of you to be here to attend the inaugural Stanford Asian Health Symposium and the Luncheon, here right in the center of Hong Kong, which is the center of Asia. This symposium is hosted by Stanford Center for Asian Health and Education, also known in acronym as Stanford Care. My name is Sally Lee. I am the Executive Director of Stanford Care. Dr. Lasa Palani, sitting there, she'll be providing the overview of the center. I also want to let you know one of our speakers, she actually, unfortunately, is not feeling well, so she'll be sending a recorded video to be played for the flash talk. All other elements of the program remain unchanged. 我想欢迎大家来，谢谢你们 attend 我们今天的这个亚洲健康论坛，谢谢。Before we begin our program, I want to thank a list of people who made this program possible. First of all, I want to thank our co-chair of the advisory board, Ms. Karen Lee, and Dr. Sheila Wang. In addition, I want to express a special thank you to the following people who really spread the words about this conference, about this symposium in Hong Kong. Dr. Carl Feng and wife Yvonne Feng, Ms. Vivian Lin and daughter Maxine. Alice Wu and Junior Pang Lee from HSBC, and Ms. Halina Kuhn from Goldman Sachs Asia. And finally, I want to thank Danke Wu, who made the trip and who came from the United States to support this event. She is a member of our advisory board, and thank you, Danke, for your ongoing support to CARE. Now it's my great pleasure to introduce Ms. Karen Lee, who is the current co-chair of the Stanford Care Advisory Board. Let's welcome Karen Lee.
Thank you, Sally. I'm very happy to be here back in Hong Kong, seeing so many familiar faces. I'm also looking forward to meeting new friends that I haven't met this before. As for Stanford Care, and this is a very, very prestigious organization. And you will learn about shortly, Stanford Care focuses on improving the health of Asians worldwide in a variety of research and education initiatives. I'm so amazed by the progress it has made in only about 5 years of time. I'm also looking forward to meeting several Stanford Medicine faculties about how their work is having a positive impact towards Asian health. In addition to hearing from Stanford faculties, and also encourage each of you to get to know with each other during our luncheon. In this room, we have so many fascinating friends, including business leaders, academic researchers, and also healthcare experts. I strongly suggest everybody will chat with each other, discussing issues, current issues, and also explore potential collaboration. Talking about fascinating people, I'd like to introduce to my fellow co-chair, a devoted Stanford alumnum and volunteer, Dr. Sheila Wang.
Thank you, Karen. Thank you. And welcome, everyone. 大家好. It's so nice, so delightful to be back in Hong Kong. It's a very special place. My husband and I spent several years in Hong Kong long time ago, but it holds a very special place in our hearts, and as do our dear, dear friends whom we have invited to join us in this event and celebration. It's so nice to see you. It's very, very special. And it's so nice to bring Stanford to Asia and to connect the two and to work on improving Asian health. We think it's a very noble mission, and it's one that we are fully dedicated towards. So happy to have you here to help us support that. During today's symposium, we will hear from distinguished Stanford faculty on the latest breakthroughs and innovations in medicine. And I think even though their presentations may be different in all of their aspects and fields, they're all world leaders in their areas, and there is a common theme. And the theme is about breakthrough and proactive and precision health. And we are so pleased to be bringing Stanford to share with you on these breakthroughs. And I think through their presentations, we hope that we will learn and we will find how Stanford is a leader in the area of precision health. And with this being said, I do want to have the greatest honor to introduce to you our keynote speaker. Dr. Lloyd Minor serves as the Carl and Elizabeth Nauman Dean of the Stanford University School of Medicine, and he is also the Vice President of Medical Affairs for Stanford University. Dr. Minor is very special, very dear to our hearts, because he is a scientist, he is a surgeon, and he is an academic leader. And as dean, he plays an instrumental and very critical role in setting the direction and the strategy for the clinical care, for research, for education enterprises within Stanford. And under his leadership, CARE was founded. Stanford Medicine has pioneered the precision health revolution, which emphasizes preventive, personalized healthcare, and leverages advances in biomedicine to treat and cure complex diseases. And it gives me great honor, and please join me in the warmest Hong Kong welcome to Dean Minor. Thank you.
Well, thank you so much, Sheila, for that really kind introduction. It's so wonderful to be back in Hong Kong. I've really missed not being here for the past 4 years. I think my last trip was in September of 2019, and prior to that, I've been here essentially every year for 6 or 7 years, and it's just wonderful to be back, to be with all of you, to celebrate this wonderful city and this wonderful culture and spirit of generosity among the people of Hong Kong. So we're honored that you're sharing a bit of your morning and afternoon with us here today, and we hope to be able to share with you some of the exciting things going on at Stanford Medicine and how that impacts what's going on in Hong Kong and around the world. I first also want to thank the Advisory Council for Stanford CARE, the Center for Asian Health Research and Education. We're so grateful for your time, your dedication to the mission of CARE, and I share your passion for what CARE has done and for what it's going to do in the future. And we put at your place a small token of our appreciation that we hope you'll enjoy and think about us when you use it, and also please know that we're looking forward to working with you on continuing to build CARE's success moving forward. And very importantly, I want to thank my faculty colleagues who are here today from Stanford. You'll be hearing from many of them. You know, I feel like I have the best job on the planet because I work with such amazing people every day who bring passion, knowledge and dedication to the work they do, to the impact that they have and the patients they care for, and the research that they do, and in the people, the students that they educate for the future. And we're delighted that we could come over to Hong Kong. Yesterday, we hosted a symposium on clinical neuroscience, and a few of you were at that symposium, but we had several faculty here for that, and we have faculty participating here today. So I wanted to, just in my remarks, share a few things with you that we're excited about at Stanford, some of the work that's going on today, and some of the work that we hope will be going on in the future and the impact that it's going to have. So let me just see. So really, I want to talk about today this new era of discovery that we're in life sciences, and how that era of discovery in life sciences we believe is going to impact and improve health and well-being around the globe. These are my disclosures of outside activities, but I'm not going to be talking about any of these outside activities in my talk today. Now first, let me explain briefly what we mean by Stanford Medicine. We are an academic medical center, so we have a school of medicine, we do research, we train doctors, we train PhD scientists, we train master's students, postdoctoral fellows, and clinical residents. And there are really three entities that are a part of Stanford Medicine. There's the School of Medicine, there's Stanford Medicine Children's Health, which is our children's hospital and delivery system for healthcare delivery system for children. And there's Stanford Healthcare, which is our adult hospital and delivery system. And together, we come together to make sure that we are leading in the three-part mission of patient care, research, and teaching. Now, what's truly unique, you could see a structure like this for many academic medical centers in the United States. But what makes us, I think, quite unique at Stanford, and what makes our academic medical center distinct, is that we are so well integrated with and such a valuable part of Stanford University. In fact, the greatest strength of Stanford Medicine is the fact that we're a part of Stanford University. Most of our facilities, our clinical facilities, our research facilities, are on the campus of Stanford University. We're right across the street from the engineering school, the chemistry department, the biology department. And the synergies that enables, both in terms of geographical proximity, but also just being a part of one great university, the synergies that's enabled by that organizational structure, I think empowers us, it makes us able to have unique impact as we build the future of life sciences and translate that future into improvements in human health. So this is a picture of our new Stanford Hospital. You know, I'm sure for each of us in this room, we're reflecting back on what we have been through individually and collectively over the past 3.5 years. We opened this wonderful new hospital in November of 2019. And one of the and there are many silver linings, I think, for us at Stanford, for me as an individual, I think for each of you, in the midst of all the tragedies of COVID-19, there are many silver linings and things that we can be thankful and grateful for. Certainly one thing that I'm thankful for is that we were able to move into this new facility to make it fully operational, and then on March 6th, 2020, at about 6:30 in the morning, I got a call from our chief medical officer saying that we had just admitted our first patient to Stanford Hospital with COVID-19. And since that morning of March the 6th, 2020, there hasn't been a single day when we haven't had patients that we were caring for with COVID in our hospital. So having this wonderful facility enabled us to provide care not only for the people in our immediate area, but for our entire region. And that's what we're there for. That's what we're here for. And our areas of focus as an academic medical center and our impact, I think, has been present in visible and tangible ways in every day of the pandemic. We were the first institution in the United States to receive authorization from the FDA for our laboratory-developed test to detect COVID-19. And for about the first 6 weeks of the pandemic in California, we were doing most of the COVID-19 testing for the entire state. And then others got their testing set up, some with our help in setting up the facilities. But this facility has enabled us to provide care. Many of you have entrusted your care to us, and there's no higher honor and responsibility for us than providing outstanding care in our facilities and with our people. Now, we've grown as an academic medical center in the past decade. Last year, we had $853 million in research expenditures. We ranked number 2 in the United States in terms of federal research dollars, NIH dollars, to U.S. schools of medicine. About a decade ago, we'd been 12 to 15. We have 1,100 full-time faculty, and we have another 1,700 clinician educators who are employed by us and who provide outstanding care to our patients and educate the next generation of physicians. And we have 6 people on our faculty today who've been awarded the Nobel Prize since 2006. I want to tell you briefly about one of them. Those of you who were at the recent Frontiers in Medicine event at Stanford got to know her there. Carolyn Bertozzi is a professor of chemistry. She's also a professor of radiology and of chemical and systems biology in the School of Medicine. And she won the Nobel Prize last October in chemistry for discovering and developing a new field called bioorthogonal chemistry. This is a field that uses biologically inert molecules to study the function of biological systems of cells without disturbing the function of those cells. Now, it would be worthy of a Nobel Prize just on that accomplishment that Carolyn made of discovering and developing this new field of chemistry. But Carolyn hasn't stopped there. She's used this new field in order to advance drug discovery and in order to explore new ways of treating complex diseases like tuberculosis and cancer. We recruited Carolyn to Stanford about 8 years ago. She had been at the University of California, Berkeley, another outstanding institution in the Bay Area. And the main reason she moved from Berkeley to Stanford was that she wanted to be at Stanford where we have an academic medical center linked to the university and a part of the university. And she told a story during her remarks at Frontiers in Medicine that in the 19 years she had been at Berkeley prior to moving to Stanford, she had started one company. In the 8 years she's been at Stanford, she started an additional 10 companies in the 8 years. And this spirit of entrepreneurialism and of innovation and of taking advances from the laboratory and getting them to the benefit of people through the process of commercialization is something that's well imbued within the culture of Stanford University. Now, about 2 years ago, I was asked to lead an initiative on considering the future of life sciences at Stanford University. In many respects, the modern history of life sciences and biomedicine can trace its origin to Stanford, with first the discovery of recombinant DNA by Paul Berg, whom we lost last year at the age of 95. Paul had been at Stanford for over 60 years, and he remained very active and a visible part of our community and vital part of our community until the very end. But Paul won the Nobel Prize for showing that he could take pieces of DNA and splice them together, put them together and recombine them. That advance and others were then developed and used by Stan Cohen, who's still on our faculty today, and a colleague at UCSF, Herb Boyer, in order to take DNA, take human DNA, and insert it into the DNA of bacteria, and to then use the bacteria to make human protein. That gave really rise to the modern biotech era. Those patents from that work led to the founding of Genentech and many other companies, and the rest is history in terms of where it's gone from there. We want to make sure that we at Stanford and the Bay Area is at the forefront of biomedical discovery and defining the future of life sciences for the next 40 years to come. And I'll tell you a little bit about what that vision is in the remaining few minutes. We think the future of life sciences is going to be defined by the convergence of three related but distinct disciplines. First, there's biology and biomedicine. How do we study the function of living organisms and of cells? Which now our ability to study the function, the physiology, the genetics of cells is greater than it's ever been. So biology and biomedicine, with advances in information sciences, including artificial intelligence, and technology, the technology that has driven so many advances both in biology and also advances in data sciences and information sciences. It's this virtuous triangle of biology, information sciences, and technology that we believe will define the future of life sciences and will help to translate advances in life sciences into the improvement in human health. And one of the areas that we want to apply and use this convergence to drive progress in is the area of cancer. You know, during the first, say, 25 years of my career from medical school up until about a decade ago, advances in cancer were characterized by great science, amazing science, but very little of that science, as impactful as it was, very little of that science was being translated or could be translated into improvements in treatment and prevention of cancer in humans. And then, starting about a decade ago, that all started to change. And it's nothing short of a revolution in cancer therapeutics that's occurred during that period of time, with new classes of drugs that empower and energize the immune system of cancer patients to go find, attack, and kill cancer cells, using our own body, our own innate immune system to fight off the cancer, both with therapeutics, with protein-based and small molecule therapeutics, and increasingly also by engineering a cancer patient's own lymphatic cells, their own immune cells, to find and attack the cancer. And that in turn is being accelerated by the application of artificial intelligence at all levels, both in drug discovery and also in terms of being able to define the best treatment for the patient at the right time. And increasingly also, we're seeing developments in surveillance. And I think within the next 5 to 10 years, there will be validated tests that each of us could have, say on an annual basis, like many of us get blood work done every year, that each of us could have that would very accurately screen and detect at a very early stage cancers that today all too commonly are being diagnosed too late. So the science is driving these advances. And then the atmosphere at Stanford, both within the university, collaborations with industry around us, with the types of companies that our faculty help to set up, that atmosphere is driving the advances and bringing them to the benefit of people. Now, let me just mention a few examples of advances in cancer therapeutics and some of the impact of those advances. One of our faculty members, Dr. Michelle Manger, is an MD, PhD, and she's a pediatric neurologist, so she takes care of children with neurological diseases. And she's, in her practice, focused on malignant brain tumors in children. Some of the most horrific cancers we can diagnose and attempt to treat. And she's focused a lot of her career on a group of cancers that are known by the initials DIPG, which stands for diffuse intrinsic pontine glioma. That just refers to where these tumors occur and their appearance on MRI scan. These tumors, DIPG tumors, are fortunately very rare, but when they do occur, they're uniformly fatal in the children that have them. And Michelle set up on her career many years ago to find treatments that had previously not been available. And working with another faculty member, Dr. Crystal Makel, who is a pioneer in these CAR T-cell technologies. These are the technologies I mentioned that engineer human immune cells, T cells, to attack cancers. Michelle and Crystal developed a cell therapy for these tumors in the children with DIPG. They developed that therapy by identifying a particular protein on the surface of the DIPG cells that was on those cancer cells, but not on any other cells in the nervous system. They developed this engineered T cell, they validated it in experimental animals, and then they used it to treat children with this disease. And they noticed for the first time in any treatment that had ever been tried in this condition that most of the children who were treated were responding, and there were very few side effects. And today, and I just had lunch at a symposium with Michelle Manger a few weeks ago, today they have one child who is almost 3 years after the onset of the therapy, who has remained with no progression of the disease and is growing and developing normally. This cancer prior to this treatment was a uniform death sentence within 6 months. And now the trials are progressing. There are now about 30 patients who've been enrolled in the trial. And this shows very good promise for being a widely available therapy, assuming that the trials, go through to completion over the coming months. Also, we're all familiar with radiation therapy that's used to treat cancer. That goes back now, it's hard to believe, it goes back almost 50 years, and also originated at Stanford. The first use of a linear accelerator to treat cancer was at Stanford with a group of faculty who working with our linear accelerator lab, developed an accelerator for medicinal uses. And radiation therapy has an important role, but all too frequently, tumors respond to radiation and then they break through and they grow again. Now, there are advances looking at being able to fractionate or deliver the radiation in a more concentrated way to thereby get up to higher doses without doing collateral damage, but also combining radiation with molecules given in the bloodstream that makes the radiation more effective for the tumor, but not as injury-inducing to surrounding tissues. So radiation therapy is becoming more precise, and we also hope that it's going to become more effective because of these combined therapies. One of our hopes also is that what we do at Stanford, we don't want it just to be applicable at Stanford. We view our role as discovered at Stanford, translated to patients at Stanford, but then extended to the entire world. And artificial intelligence offers an amazing opportunity and ability to do that. This slide describes a study done a few years ago. It was published in 2017. And it's a study resulting from a collaboration between computer scientists at Stanford and dermatologists. what they did was to take pictures of thousands of skin lesions, growths on the skin, and for each of these pictures, there was a known pathological diagnosis. And so they used the picture combined with the pathological diagnosis to train a neural network model. And then after they trained this model, they gave the model new pictures that it hadn't been used to train on and asked the model to make a diagnosis. Is this cancer or isn't it? And then they gave those same pictures to a group of board-certified trained dermatologists. And the model, the AI, was just as accurate from the picture in making a diagnosis as the dermatologist. Now, not every community in America has a dermatologist. And there are many areas of the world that don't have any dermatologists. But now, empowered with techniques like this, a doctor in rural America or a doctor in a place where there aren't any referral centers around can have the same access to diagnostic accuracy that a doctor at a major center can. And then finally, there's been this revolution in understanding the function of single cells, but then how do cells interact with one another? We have a group of also computer scientists working with clinicians to look at glioblastoma, malignant brain tumor in human, and look at how the physiology of individual cells in a tissue sample from, so not just one cell, but the physiology of an individual cell, but surrounded by other cells where we also know its genetics and physiology. And look how that can be used to predict how aggressive the tumor is going to be. And from that study, now, from a pathological section of the tumor, it's possible to say with good accuracy, this tumor is going to progress rapidly and therefore needs the most aggressive therapy, or this tumor is likely to be slow growing and may not have to be as aggressively treated. That's one example, but there are many other examples that will follow in other tumors using this technique. So I'm really honored to be here. I'm grateful to have the opportunity to share some of our advances. We look forward to partnering with you, continuing to partner with you. Certainly for those of you who come to the Bay Area, we welcome an opportunity to get together with you. And what you're going to learn about next is some of the amazing work that's being done for the Center for Asian Health Research and Education. This center was founded by a group of faculty and volunteers with a profound passion on bringing the best advances in medicine to communities that haven't necessarily been well served by those advances in the past, and by specifically studying some of the diseases and conditions that disproportionately affect Asian communities, including Asian Americans, Asians, Hawaiian, Native Hawaiians, and Pacific Islanders. And this vision is already having enormous impact. And it's now my pleasure to introduce Dr. Latha Palaniathan, who's going to tell you more about CARE and some of the amazing work that she and her colleagues are doing. Latha?
Thank you, Dean Miner. The dean has a very Asian characteristic in that he's very modest. And he did not tell you that Stanford is one of the top 3 universities in the world and the only one to have a Center for Asian Health Research and Education because of his visionary leadership. He understands that in order to have precision health, you have to study all populations, and largely Asians have been understudied and left behind so far. And I'm lucky to have many of my colleagues here today. Please raise your hand if you got on a plane to fly here over the Pacific Ocean. I know there are several of you. Yes, okay, great. Thank you for doing that. This is largely due to the vision of Dr. Sheila Wong, our board chair. Months ago, she had the vision of gathering us all in Hong Kong, the heart of Asia, as our executive director, Sally Lee, told us, because it is where new discoveries are going to happen so we can provide precision health for everyone in this room and your families to live longer, healthier lives. So today I'm going to give you a little bit of the background of the Center for Asian Health Research and Education, which we founded in 2018 under the auspices of Dean Miner. I'm going to talk just a little bit about the health differences that we know about in Asian populations, and what you'll learn is that there's much that we don't know about. And Stanford is a unique place to discover these differences because of our rich heritage of Asian populations over hundreds of years. And then finally, we'll talk about a call to action for precision Asian health that, along with the community here and worldwide, we will be able to affect health for generations to come. So let's talk about the demographics of Asians. So Asians make up 7% of the US population, but 60% of the world's population. And they make up 30% of the Bay Area population around San Francisco and Stanford, which is why it is such a good place to study the fact that Asians make up 60% of the world's population. Half of the world's research is funded from the United States, from the National Institutes of Health. And despite the fact that 60% of the world is Asian, only 0.17% of NIH funding goes to Asian health research. This is why many of the wonderful innovations that Dean Miner has shared with us have not yet been translated to Asian populations, and that is what the Center for Asian Health Research and Education is for. So many of the drugs and devices that are used in people go through clinical trials to assess whether they're safe for use in all populations. Asians are underrepresented in those clinical trials. In the right-hand pie graph, you can see that Asians only make up 11% of people in clinical trials. On the right-hand pie graph, as I told you, Asians make up 60% of the world's populations. So we are underrepresented in testing of drugs by a factor of 5. This is a picture of me as a child and my father. He emigrated to Michigan in 1976, and unfortunately he died of a heart attack when he was 39. And I went into medicine to figure out why early heart disease was happening in South Asian populations. And when I looked at the data, it said that Asians don't have increased risk of heart disease in the United States. And I'll show you a heat map in an upcoming slide. And this is because when Asians are averaged together, with some groups having higher risk and some groups having lower risk, it looks like there's no difference. And we have missed important signals in the United States on Asian health. And while some groups like South Asians and Filipinos have higher heart disease risk, other groups like Chinese, Japanese, Koreans have higher cancer risk. And my colleague, Dr. Juhal Wong, will be talking about his specialty, gastric cancer, in an upcoming talk. So this is why we founded the Center for Asian Health Research and Education. We have many faculty that have been doing this in their spare time because it's not funded. Only 0.17% of research by the NIH is funded in Asian health. And this is what we're hoping to solve together with you as a supportive community. So our vision is to become the premier academic leader in precision Asian health. And this can only be done at Stanford. It is uniquely Stanford because 30% of Stanford healthcare is Asian. This is the only place in the world that we can do this. And also because of the deep bench of researchers that Dean Miner has already showed you, that we have the ability to transform what we can do for Asian patients at Stanford. So our mission is to improve the health of Asians by increasing knowledge, empowering education, and positively impacting their clinical care. And we do this by increasing research, and as you'll see, Very little research has been done in Asians, and the little research that has been done shows us that there's important problems that we need to solve. We aim to educate patients, providers, and the community, as we're doing here today, around the world about the health needs of Asians. And we aim to improve the culturally sensitive and evidence-based delivery of precision healthcare to Asians. So this is just a brief overview of the major health differences that we've already identified. And as I mentioned, we have a long way to go. So with regard to diabetes, Asians develop diabetes at lower levels of body weight. So it's not the obesity-related diabetes that we often see in European, non-Hispanic, white American populations. And this is because there is less muscle mass. And I have done a study recently that was published that shows that strength training is more important for improving diabetes than aerobic training that most people normally do for their exercise. Also, depression, mental health is an important concern in Asian populations. And depression presents differently in Asian populations, more often with somatic symptoms. So people complain of headaches and stomach aches and don't complain of the lack of pleasure in doing things, anhedonia, or hopelessness that's reported in Western populations. So we need to study mental health in Asians better because this is a crisis that is happening in the United States and has also been reported in Eastern populations as well. Gout, I'll show you an example of a common medicine that is used to treat gout in Hong Kong and the world over. And allopurinol is associated with a genetic difference in Asians that causes a more severe cutaneous skin reaction. And I was speaking with someone in the audience who worked with other drugs, carbamazepine in seizure disorders, that also causes more severe cutaneous skin reactions in Asian populations. And this was not discovered before Asian populations were well studied. Gastric cancer, Dr. Juha Wong will tell you more about that. We'll learn more about heart disease with Dr. Alan Young, and there's differences in cholesterol medications. Asians need to take lower doses of certain cholesterol medications. Cardiovascular disease, I gave you the example with my father dying earlier of heart disease. Alcohol flush syndrome, there's differences in ALDH2, which is more prevalent in people of Chinese heritage, and this is related to higher cancer risk. Hepatitis B, which is important in Hong Kong and is related to liver cancer risk, and nasopharyngeal cancer is more common due to increased Epstein-Barr virus. And there's much more, and I'm fortunate that my colleagues at Stanford focus on Asian health differences from birth to older age. And it is this deep bench of researchers that can be activated with more funding for Asian health research so we can provide precision care for Asians. So now let's try to summarize all of the research that my wonderful colleagues are doing in Asian health with a heat map of Asians. So these are the 6 major Asian subgroups in the United States: South Asian, Chinese, Filipino, Japanese, Korean, and Vietnamese. And as I mentioned, you can see across on the rows from cardiovascular disease down to thyroid cancer that there's variation across these Asian subgroups, and these are all aggregated in the data. How many people here work in healthcare? I know there's many of you. And I want to ask you to ask yourself, every time you read a paper, does it say Asian? Does it tell you the specific Asian subgroup? Because when it just says Asian, we're missing all of this variation because we're lumping all of these groups together. And this is what we need to change going forward. So let's focus in on the Chinese population. Dr. Heather Wakely has some recorded remarks, and she'll be talking a little bit more about lung cancer. And I'll tell you briefly about liver cancer. So liver cancer is the 3rd leading cause of cancer death in Hong Kong. And this is largely due to virally mediated disease through hepatitis B virus and hepatitis C virus. And 75 to 80% of the hepatocellular carcinoma, liver cancer, is related to hepatitis B infection. and only 50% of hepatitis C and hepatitis B infections are diagnosed, and only about 10 to 12% are treated. So hepatitis infection can lead to chronic hepatitis, which leads to cirrhosis and leads to liver cancer, and this can be interrupted all along the pathway with better screening and treatment efforts. And thanks to SAMSO, there's now a bill passed in the United States to test for hepatitis B and C for all Americans, and we hope these types of policy initiatives can be brought around the world to apply what we've learned in the United States to improve cancer deaths, and also to import knowledge from countries around the world with cancer screening programs, for instance, that are prevalent in Asian countries that we need to implement in the United States to take better care of Asian populations around the world. I'm going to touch briefly on pharmacogenomics. So pharmacogenomics is the study of our genetic responses to drugs. Allopurinol is an example, and it's a common medication used in gout, and it is used quite commonly in Hong Kong. And one of our patients came to Hong Kong and received allopurinol here and got a severe cutaneous skin reaction due to a genetic variation in HLA 5801, which is much more common in Asians, 7.8 times more common in Asians. And in Asians, it's 3 times more likely to cause this severe cutaneous skin reaction. So I'll tell you a little bit more about pharmacogenomics in the next talk. So in summary, we've been able to use national and international data sets, electronic health records, and mortality records from in the United States and around the world to study big data in Asian health. Our future directions are working with people around the world to create conferences and collaborations, and a few that I will mention is our conference in traditional Asian medicine that was funded by the Vincent C. Wu Foundation and led by Dr. Gloria Kim, and also conferences in gastric cancer with Dr. Juha Wong we'll talk about. We had COVID conferences with representation from the Hong Kong Public Health group. We also have community health talks, and these have been spearheaded by our executive director, Ms. Sally Lee. And these are also available in Chinese, and they are available on our YouTube channel, and there are hours of talks on all of the various health conditions that I have mentioned by our esteemed faculty who are experts in all of these areas. We also have a summer program that is virtual, and we invite your students and trainees to participate in this. It is led by Dr. Malathi Srinivasan, who focuses on big data and many of these national data sets that I talked about and international data sets, artificial intelligence, and global health to help the next generation of healthcare leaders in Asian health. We've also started a Journal of Asian Health in 2020, and this is led by Dr. Paul Wong, who is a cardiologist in Dr. Alan Young's, under his leadership. And the mission is to contribute to the understanding of social and medical determinants of health in Asians in the US and elsewhere. And it is often hard to get research in Asian health published, and this is nice because we will have a home for this at Stanford. I encourage you to look at our website, and thanks to Sally Lee, we have a wonderful annual report, and this will be updated this year, and it really focuses on our impact over time, which we hope to continue to grow with your support. So our call to action here today in Hong Kong. We need more research funding in Asian health. As I mentioned, the NIH, which funds half of the research, world's research, only expends 0.17% of its funding on Asian health. And we need to discover new genetic, pharmacogenomic, and gene-environment interactions that will improve our understanding of health in all populations. We want to increase international exchange And Dr. Gloria Kim will be talking about this in her remarks on the educational exchanges that she has spearheaded through the Chi Li Pao Foundation. And finally, we want to create precision healthcare for Asians everywhere. We are only at the tip of the iceberg, and we want to educate the international Asian community about important health risks and pharmacogenetic and genetic differences in Asians. So thank you. With that, I'll conclude my care overview. So we have a rather long program today and many speakers and flash talks. I encourage you to please get up and avail yourself of the refreshments in the back of the room. There are restrooms out in the, to the right if you'd like to take a break at any time. And we have pads of paper at every seating area. And if you'd like, please write a question down as we go along for the speakers. And Dr. Juha Wong will be moderating a panel. And we're happy to answer your questions as well. Okay, now I'm going to move to the role of genomics and pharmacogenomics in precision medicine. And as many of you know, we have over 3 billion base pairs in every single one of our cells. And all humans are 99% the same. All race ethnicities are 99% the same. The less than 1% that is different is what leads to the impactful health and pharmacogenetic risks that I told you about briefly in the previous talk. So why is it important to study diverse populations? When we study diverse populations, we can find differences in biomarkers, differences in safety and efficacy, and this can lead to new scientific discoveries. So you see here a world map, and by studying diverse populations around the world, we have improved our knowledge of pathophysiology, we've discovered new treatments, and we've been able to personalize care. And I'll focus on the right-hand side of the map, what has been found by studying East Asian populations specifically. There's a mutation that was discovered in East Asian populations in EGFR, and this may explain in part the higher lung cancer rates that we see in Asian women in particular that don't smoke. And Dr. Heather Wakely will be talking a little bit more about this in her talk. I mentioned a little bit about the human leukocyte antigen differences that lead to pharmacogenetic more adverse reactions with allopurinol. There's also an HLA, human leukocyte antigen variation, that leads to severe cutaneous skin reactions with carbamazepine, and we were talking about that earlier, that carbamazepine is prescribed, but this is not often tested for in Asian populations. I'm going to talk a little bit about gene-environment interactions and what we can learn by populations that immigrate. And many people in this country have lived in different countries, including the United States. And thank you, Dr. Wong, for sharing that you used to live in Hong Kong and emigrated to the United States. And there's differences in diet, exercise, cultural differences, smoking rates. And we see this play out as people emigrate around the world. So cardiovascular disease we'll look at in the two largest countries in the world, India and China. And when we talk about cardiovascular disease, there's differences in brain atherosclerosis, so blockages in the brain versus blockages in the heart, which Dr. Alan Young will talk to us more about. And in China, when we talk about cardiovascular disease, there's more of a stroke prevalence. Yet in immigrant populations of Chinese ancestry in the United States, we see more of a heart disease prevalence. And this may be due to differences in diet, such as increased cholesterol in the dietary intake of cholesterol, increased smoking rates, and starts to mimic more the cardiovascular disease prevalence that we see in non-Hispanic whites, where there's more heart disease and less stroke. In contrast, in India, where my father emigrated from, there is more of a heart disease prevalence, and when we see immigrant populations in the United States from South Asia, we see even a more highlighted heart disease prevalence, and this may be due to the populations that do emigrate have a founder effect with some mutations that are more common and variants that are more common in South Asian populations. And as I mentioned, Asians are underrepresented in clinical trials, and similarly, they're underrepresented in genomic trials. So whenever you see the headlines that we've made some new breakthrough in polygenic risk scores, for instance, to predict disease, those are indeed advances, but we find that those polygenic risk scores don't work as well in diverse populations, particularly Asians, because Asians are not represented in genetic databases. So this is work that is done by some of my Stanford colleagues, and you can see that we've improved. Asians in 2009 made up 4% of the genetic databases, and that has increased fivefold in 2016, but still 80% of the genetic databases are people of European ancestry. And as I mentioned, Asians make up 60% of the world, and they're underrepresented by a factor of 3 in the genomic databases. And hopefully we can work together with our colleagues in Hong Kong to address this disparity. And because of this, decisions around Asian health are made mainly using non-Asian data. So when we open up our textbooks, all of us around the world, there is very little information on Asians to guide us, and we are flying blind in terms of taking care of our patients. And here is one example of pharmacogenomics and how it's important in taking care of patients. So this is a study also funded by Dean Miner called Human-Wide. And one of our patients was reluctant to get a surgery because the medications that we use for pain control after surgery, Vicodin, which is a codeine drug, is activated by CYP2D6 in the liver. And she had poor metabolizer status for CYP2D6, and she couldn't get the active form of the drug, which was morphine, which meant that she had all of the side effects of taking morphine, so nausea, delirium, constipation, but she didn't have any of the pain relief effects. So pharmacogenomics is understanding how our body responds to drugs based on our genetic code. And at Stanford, I founded the first pharmacogenomics clinic where we do a saliva swab, and it tells us 25 different variations in your genetic code that tells us your response to over 400 drugs. The FDA approves drugs when they work for a majority of the people in the bell curve. So 80% of people respond to a normal dose. There are people on the ends of the bell curve that are intermediate metabolizers that respond to a lower dose, ultra-rapid metabolizers on the other end of the spectrum that may respond to a higher dose, and some, as I gave examples with allopurinol and carbamazepine, that need an alternate drug because they have adverse reactions. And we talked a little bit about allopurinol in the previous talk, and I'll move now to other pharmacogenomic differences that you should be aware of, and please ask your doctors about this. If the drugs have been tested in Asians, as I mentioned, Asians are underrepresented in clinical trials by a factor of 5. There's a loss of function mutation in CYP2C19, which is an enzyme that metabolizes clopidogrel, which is a drug that we give to people to keep stents open. And Dr. Alan Young will be talking to you more about that. And this loss of function mutation leads to more thrombosis. It means the drug doesn't work as well in Asians. For statins, which is a drug that I give often as a preventive cardiologist, Asians are recommended to have lower doses, and there's an FDA labeling on Crestor to start at lower doses because this has been studied in Asians, and there's more side effects, musculoskeletal symptoms in Asians. And also warfarin, which is a drug that we give to prevent clotting and atrial fibrillation and other conditions. Decreased dosing is recommended for Chinese due to differences in CYP2C9. And I want to give a shout out to Dr. Carl Fung, who visited us at Stanford and is starting pharmacogenetic testing in his practice here in Hong Kong. And this is a paper that we wrote through Stanford Care, talking about the pharmacogenetic differences in Asians, I encourage you to familiarize yourself if you or your family members are taking drugs, and ask yourself, has this been studied in Asians, and are there important differences that I should know about? So the key takeaways are that Asian genetics and pharmacogenetics are largely understudied. We still have a lot to learn, and there are important disease and treatment differences in Asians that still have yet to be discovered. And more funding is needed to achieve the vision of precision health for Asians. So thank you for your attention to this flash talk. And it is my honor now to introduce my role model in cardiovascular medicine, Dr. Alan Young. Dr. Young leads the cardiovascular health service line, including cardiology, cardiovascular surgery, and vascular surgery, which ranks as a top cardiovascular program in the United States and the world. Dr. Young provides care for the complete range of cardiovascular conditions such as coronary artery disease, heart valve disease, and holds patents for innovations in cardiac care. And those of you who know him know that he is born and bred in Hong Kong and has been a leader in work across the world in cardiovascular disease. So welcome to the stage, Dr. Young.
Great. Thank you, Latha. It is always exciting to come home, even though, I've been back to Hong Kong 4 times this year, but every time it's new and fresh because you get to see new friends, meet our old friends, but in a new way, and also see my family, and never to sort of stop about not having food, right? The food is always, what entices you to come home. So my talk I think is important, and I think sort of emphasize what Lloyd has talked about and Latha has talked about, is curing disease. So curing cardiovascular disease one patient at a time, meaning that we have to focus each of you a little differently. We'll talk about precision, personalized medicine as well. So just give you a little sort of a background. So we've been doing this for quite a long time, because when I came back from Boston to Stanford in 1993, the first thing I did was look sort of westward and say, well, how come we don't do anything in Hong Kong? And obviously we consider ourselves as a Pacific sort of country. So this is the first symposium we put up in 1994 in the Grand Hyatt Hotel when it first opened. And that's at that time with no PowerPoint, so we had to make these by hand and carry it to Hong Kong. So at that time, we also talked about curing heart disease or help, treating heart disease. This is me, of course, and with my old boss at that time, Dr. Victor Zhao, also from Hong Kong, trained in Canada, and obviously can read Chinese, is really talking about cholesterol, talk about genetics, and talk about stopping smoking. I remember my talk at that particular symposium to the general public is talking about, should you have dim sum for lunch? So I would say the same question still today is that whether you should have dim sum for lunch. So, but for 30 years, we have made great progress in terms of really curing heart disease, not treating heart disease, and I'll show you how. So while we talk about heart disease, is really one subset of heart disease. We're talking about coronary heart disease, meaning that those are little arteries on the surface of the heart, tiny, they're going about 3 to 4 millimeters, but when it blocked up, has great consequence, meaning that the blood flow to the heart is stopped, the muscle cannot pump, arrhythmia or extra beats, very sometimes fatal, can happen, and therefore these tiny little arteries is really what we're focusing on as cardiologists to keeping them open. So what happened to these arteries? This is sort of a schematic of these little tiny arteries. On the left, you can see the normal arteries. Essentially, the wall is very thin. The majority of the artery is this open hole to carry blood flow. But as you sort of progress in terms of your risk factors, whether it's eating habits, whether it's genetics, whether it's your other environmental effects, you can build up these plaques. And at some point, the hole of the arteries get very small and restricting blood flow and causes you to have symptoms of whether it is shortness of breath, whether it is chest pain on exertion or when you're doing something. That's sort of the buildup of heart disease. Well, this is actually quite easy to treat because you will come to see me and say, well, I have symptoms. The part that is a little bit more scary is actually most of us, as you know, might have friends. Can you click on this to see whether it can play? Seems like not. able to play this. It's a little movie. Oh, okay. So this is a sort of a time-lapse picture, if you may, of what is building up in the heart artery. This is similar to what I just showed you, but at some point in time, because of the buildup is so quick, the heart artery is very inflamed. And what happens is the surface of the heart can rupture, and the inside of this plaque can cause clotting to form on top of that hole. So therefore now there's no more blood flow going to the heart. You have a heart attack, and if it's a big enough artery, you obviously can have very dire consequence. But this is, what I've been working on in the last 30 years. We can open up these arteries very quickly if you come to the doctor or the hospital sort of quite quickly. So on the left, you can see the artery is cut off. We put some dye into the artery. There's no artery coming after that little spot. But we can basically quickly send a little wire through, open it up, and restore blood flow. So this is how you treat these heart attacks. Relatively straightforward, and we have systems developed worldwide now to treat these patients within 60 minutes from the time they present. So how do you actually treat heart disease? Obviously, there's three major sort of choices. The number one and the most important one is medication that changes your risk. And I think Lartha talked about that already. Is majority of the time is cholesterol-lowering medicine. But in the last decade or so, there's also injectables that you can get, that if you cannot tolerate medicine, you can get these shots once a month, a couple times a month, or every 6 months that can drastically lower your cholesterol to the range that you can never done with oral medication. So the foundation of treating heart disease is actually medicine that treat your cholesterol, your diabetes, many new medicines as well, and obviously stop smoking as well as exercise to keep your sort of muscular mass high. Another piece, obviously, treating once you have trouble is what we call angioplasty, stenting, or tombotai, right? Something you can see that on the left side, there's a little, very little narrowing in the beginning of the arteries, almost like a beak. So the blood flow cannot go down very easily. Again, relatively straightforward to fix this. We send a little wire down, we open that part and put a stent in. You can see now very nicely open. The third option, which we don't want to have, right, because it's an open heart operation, is coronary artery bypass. So what we are talking about nowadays is that still majority of the time we are spending our effort in secondary treatment. Once you have symptoms, whether you have a heart attack, and we try to prevent it from coming back. We also have worked on primary prevention, treating your risk factor, right? Treating your blood pressure, treating your cholesterol, stop smoking, treating your diabetes, and also encourage you to exercise. But what we have moved towards the left now is called primordial treatment, meaning that we don't want you to have these risk factors also. So really trying to reduce the onset of your risk factors. So that's really where we should be focusing on. The problem is that those are very big concepts. We know treating your blood pressure, treating your heart, your cholesterol will work as a population. But on the left, anybody know who that is? So Jim Fick is an exercise marathon runner, and basically he passed because when somebody did his autopsy, he has three vessel disease, meaning all three arteries are blocked up. So obviously exercise didn't help them, but people who don't want to exercise always quote him, say, hey, look, he exercised and he still has heart disease. And then on your right, you obviously know who that is, and now he is smoking. And people who smoke and say, look at him, he smokes, and how come he doesn't have heart disease? So as individual, we have not had good handle of who gets heart disease, who does not. And as a population, we have great handle. So what can we do? So this is what we are doing in 2023. We've been focusing on the whole of the donut, right? Because the opening of that artery is very important, no question. But we forgot that the action is actually in the wall of the artery. So here is really represented as the atherosclerotic plaque. The reason we don't focus on it is that we cannot see it so easily. So the way to look at it, we have a technology to look at it now, and also actually have been for a few years, but involve a procedure. It's an angiogram, and we put a little camera inside the heart artery and get these slices of the heart artery like a loaf of bread. So we can see that the whole of the artery in all these pictures on the top is not too bad. It's a pretty good size. But if you look beyond it, there's a big piece of plaque behind it, right? The donut wall is pretty thick. And if you calculate what is the percent of that vessel has a plaque in it, it runs around 60 to 80%. So this patient, if you look at his artery, you say, oh, he doesn't have any blockage at this point. It's okay. He's not okay because he has a lot of plaque buildup, and he has a little bit further plaque buildup, he'll be in trouble. So now is really what we're talking about is getting CAT scan. You have CAT scans in Hong Kong, getting an coronary CTA, we call it, is pretty straightforward. And you can get good pictures on the middle here. For example, you can see there's a narrowing. You can confirm it with an angiogram. You can see calcium build up in the heart artery. No problem. But the trouble is that you cannot see the detail of the wall that well. And now the newer generation of CAT scan developed also at Stanford. There's a proton counting CT, so getting very detailed information back from the heart artery. And then we can lay out the artery and basically start to measure, and that's a little movie there, what are the different composition of that wall there. So essentially I just showed you that in a procedure you can do it non-invasively. So this is still currently not available clinically, but you can see how helpful that be to really start to look at what is the characteristic of the plaque, how much are the plaque. This can be done manually, but will take probably weeks to do one patient. But obviously using machine learning and algorithm, the machine actually can predict and calculate the next frame and make the procedure done in a very short time. You can see all the characteristics we can measure on the right-hand side as well. So the simple message is that you can actually start to call these plaque, whether they are low density or sort of not low density, meaning that they are sort of intermediate, and then the hardened ones, which are calcified. So many of you may have calcium score. You can measure how much calcium is deposited in the wall. But what is really important is that the low density ones are the ones that will rupture, the ones that will actually clot. So what you need to do is turn these low density plaque, which are the dangerous one, if you may, turn them to the bright ones, because they calcified, essentially harden and stabilize the plaque. So therefore, turning dark plaques bright is the idea to prevent heart attack. So also with this technique, then you can start to measure the total volume of how much plaque is in your heart artery. So instead of measuring one little slice, we are saying that, okay, you have greater than 750 millimeter cube of plaque in your artery. Obviously, if they're laid out very evenly, there's not a lot for each slice. But if you concentrate in a couple of spots, it can be narrowing the heart artery. So you can stage them, whether they are mild, whether they are moderate. And the nice thing about it is that you can measure it again, right? Because no procedure, non-invasively. So if you treat your cholesterol very aggressively, the next year, for example, or 2 years, you can start to measure all those parameters again and see whether you have stabilized your plaque, whether you have decreased your plaque volume. So this is really a new way of really concentrating the culprit, which is not the whole of the artery, is the wall. So here, we're just representing three patient. Some have severe disease, some have moderate disease by this technique, and some have mild disease. But turns out, as I said before, some of these, what they're doing is nothing to do with what the plaque are doing. Like this first patient actually is a marathon runner. But why did she run marathon? It turns out maybe she has a family history. She actually has high cholesterol, but in the past there's no treatment for it. So she thinks by doing exercise, by doing over a lot of exercise, maybe she can help with her risk, which did, but maybe not enough. So she obviously needs much more treatment. And for example, the moderate disease one clearly need more treatment. And somebody that may have other risk factors, but no plaque, maybe they don't need all the whole 10 pills that they need to take a day. So I think this sort of more personalized, more precise treatment of heart disease using data, I think is the way to go. But it is easy for me to sort of tell you a story. Sounds right, sounds kind of great, but we have to prove it, just like in any clinical science. So there's a trial we're going on at Stanford with basically taking patients and sort of treat them in a traditional way. Don't look at the CT, just treat their cholesterol, treat their diabetes. And the other way is just what I talked about. Classify them whether they are mild, moderate, severe disease, and treat them according to what the artery looks like. And then see what happens. So thank you so much for listening to me, and I'll be around to answer the questions after. Thank you. I'm going to introduce the next speaker. It will be by recorded video. Heather Wakely is the Deputy Director of the Stanford Cancer Institute and Professor of Medicine in Oncology, and the Chief of the Division of Oncology as well. She's going to talk about advances in systemic therapies for early-stage lung cancer.
Be with you in person, and I'm going to be talking with you about lung cancer. Just get this set up. I'm going to be focusing on advances in systemic therapy for lung cancer. Lung cancer is a leading cause of cancer mortality among Asian Americans and Asians in Asia. And this is a breakdown by different ethnic groups. We know that most lung cancer is associated with smoking, but a growing percentage is associated with people who have never smoked cigarettes. This is some data that was gathered in Taiwan, showing an increase in the adeno type of lung cancer, even though smoking rates are coming down. And this is true for both men and women, but particularly striking in women. We're doing work in California on what's called the FAN study, the Female Asian Never Smoking Trial, where we are identifying women who are Asian American who have developed lung cancer and looking to find others in their community who are like them in all aspects except that they don't have lung cancer, and then doing very detailed questionnaires as well as samples, genomic samples from buccal mucosa, hoping that we might be able to get further leads as to why people who don't have a smoking history are getting lung cancer. When we do find lung cancer, it's very important to try to find it early. This is staging. When we look at these curves, what we're showing is at the top, that 100% means everybody's alive to start with. And then as time goes on, which is measured in years at the bottom, unfortunately, people are dying. And so the blue, stage 1, these are patients who are living the longest and doing well. Patients who are identified at stage 4, unfortunately, many of them have died within the first 2 years. And so you can see that if we can find lung cancer early, people do better. And that's been a really important focus. And that's lung cancer screening. And there's been a huge emphasis on trying to improve screening. And Taiwan has been a leader in some of the work where they did a trial identifying people at risk based on family history, and they have started to operationalize that as well. Now, what I'm showing you here is another one of those survival curves where we start off with everybody alive, and over time, things happen, and unfortunately, people lose their lives to their disease. But what we're showing here is that in this group of patients, some received chemotherapy after surgery and some did not. And the group that got chemotherapy seem to do just a little bit better. Those curves have only separated just a little bit. So they are doing better, but not a lot. And I want you to kind of think about what this curve looks like, because I'm going to show you others where we have treatments that have more benefit. Now, I'm going to confuse you a bit more. I've talked about lung cancer. I've talked about lung cancer that can come from very different reasons. But when we talk about lung cancer, it's no longer just one disease. There's several things we need to think about. And one is, in order to get a cancer, you need to have genetic changes, gene tumors or genes that have changed in the tumor, so mutations. And those are mutations, changes in the genes that are only in the tumor and not in the rest of the person. And we've figured out that if we can figure out the specific genes that have changed in a particular tumor, we can actually frequently give very different treatments based on that. So what is this circle I'm showing you? What it's showing is that in the outer circle, this is an Asian patient population with lung cancer, showing that almost half have a specific gene mutation called EGFR. About 20% we don't know what the gene is, and then these other colors are all different genes where if we find them, we can give people specific targeted treatment. This is in the metastatic setting. When we look at a Caucasian population, the percentage with EGFR is quite different, though many of the others are similar. So this becomes important because if we can understand what's going on in a specific person's tumor, we can treat it differently. And we know that the frequencies of these genes are different in Asian populations and non-Asian populations. And that's one of the other things we're trying to understand as to why. What is leading Asian populations to have mutations that lead to these cancers? Now, another big change that's happened in treatment for lung cancer is with what we call immune therapy. And these are drugs that get the immune system to better recognize the tumor and attack. And the main one is this gene called PD-L1 and PD-1. I'm not going to go into too many details, but essentially, that's one of the stop signals. And if there's high levels of PD-L1 on a tumor, the immune system won't recognize or attack the cancer. But if you block that stop signal, then it's not seen and there's a better attack on the cancers. So I've talked about these targeted treatments when there's specific gene mutated in a tumor, and then we've got very specific pill drugs that work there. And now about immune therapy, where we can give treatment that can get the immune system to better recognize the tumor. And why does that matter? Well, this is the main point. I'm getting to talk about some of the early stage treatment advances. But just to kind of summarize a little bit here, non-small cell lung cancer is a major cancer killer in Asia. Rates of some lung cancer, particularly in people who have never smoked, are increasing. Early stage lung cancer can be cured. Chemotherapy improves outcomes just a little bit. But in advanced stage lung cancer, we now have these targeted therapies and immune therapies. And now we're looking at how can we take that into earlier stages of cancer and cure people. So let's first talk about treatments that we can give before surgery. Well, remember I talked about those immune therapy drugs. Well, it turns out if you give just a couple of doses of one of these immune therapy drugs, the tumors actually can shrink. And then you see that when you take the patient to surgery. So that was very exciting discovery. And this was a trial. So this is a schema showing the type of people enrolled in the trial, and then people either received this immune therapy drug, nivolumab, or they didn't. They just got the chemo. And again, this is before a surgery. Then people went to surgery. And what this is showing, remember this curve, starting at the beginning, everybody's alive and doing okay. But over time, people die of their disease. And what we're showing here is that the people who got the nivolumab, that immune therapy, and the chemo, more of them were living longer. And this is actually event-free survival, not just living, but living without the cancer returning. And so there's a higher proportion of people living without the cancer returning if they had immune therapy. And this was a big development, and it changed practice. And this is that overall survival, showing that if we can prevent the events from happening from the cancer coming back, that's actually going to lead to people living overall longer. And that's what we see here. Now, there's also treatment that's given after surgery. We call that adjuvant. And this is a trial I was involved in. This is the Empower 010 trial. And here people had their surgery, and then they got chemo, and then they got immune therapy. And here also, the cancer coming back it's less likely to happen in people with that atezolizumab, the immune therapy here. So we're starting off 100% of people doing okay, and then when over time, more people are living without their disease coming back if they got the immune therapy. And this is also leading to overall survival improvements at this point, particularly in patients where their tumor has high PD-L1 levels. Okay, now I've talked about giving treatments before, giving treatments after. We can actually give immune therapy both before and after. And there was a series of trials that were done. This is one of them. Again, showing that separation of the curves where people who got this immune therapy drug both before and after surgery are doing better than if they hadn't. This is a trial that was completed exclusively in mainland China, the different immune therapy drug, and that also showed a very profound benefit. And we see the same in this trial, the Keynote 671, where I was able to lead this trial. And we see that same, when you give immune therapy before and after, more people are living without their disease coming back. And that we think will lead to a definitive overall survival benefit, but it takes a while, which is a good thing, before we get to those numbers. However, immune therapies can set off autoimmune toxicities, so we don't want to treat everyone unless we need to. So I'm going to talk now. I've talked about immune therapy. You're like, probably remember I talked about targeted therapy. So what does that have to do with early stage lung cancer? Well, remember that EGFR mutation I talked about. It's very, very common in people who develop lung cancer who are in Asia or of Asian ancestry, especially if they don't have a smoking history. And we have many drugs now that work to treat it. This is a trial that looked at patients who had that EGFR mutation in their tumor, and they'd already had surgery, and they got one of the EGFR targeted pill drugs. And we see that over time, the group that got the pill drug were much less likely to have the cancer come back and be alive than those who did not. So this has changed practice. And this is looking at that disease-free and overall survival showing that benefit. Okay, so it's a lot of information. And I'm going to now talk about one other concept, which is about circulating tumor DNA. This is a way we can look to see what's going on with the cancer just from blood. And what we see is that the tumor releases little bits of its tumor DNA, which can be identified with very special technology. Now, there are many, many companies starting to do this, but I work at Stanford, of course, and we've been some of the pioneers with this. So this trial was looking at patients who had early stage cancer, had radiation or surgery, and then we looked to see did they have any evidence of that tumor DNA in their blood still. And if they did not, patients did really well. That's a black line. And if they did, then unfortunately their cancer came back. And so now this is something we're trying to use to figure out who needs additional treatment and who doesn't. And this is from one of the other trials, again, showing that we can separate out who needs the treatment, additional treatment more, and who perhaps could skip it in the future. And this is a trial we're doing at Stanford, looking at one of these immune therapy drugs, combining it with that ctDNA technology, where we look to see for a patient who had their surgery, if they have any evidence of that tumor DNA, and if they don't, we watch. And if they do, then they get additional immune therapy treatments. So to summarize all of this, lung cancer is a major cancer killer in Asia and globally. Screening and identifying lung cancer at early stage improves cure. Dramatic improvements for advanced stage with targeted and immune therapies. Immune therapy before and after surgery improves outcomes. Targeted therapy given after surgery improves survival. And ctDNA may help to prevent overtreatment in the future. And it's really important that we understand each individual tumor. That's how we are allowed to have optimal care for each patient, and that's a lot of the groundbreaking work we're doing. So thank you very much.
Thank you. Next, I'm going to introduce Dr. Juha Huang, who is MD, PhD, and he's going to talk about gastric cancer as an Asian disease. So a little bit brief introduction on Dr. Juha. He is a pioneer in the field of endoscopy surgery. Dr. Huang specialized in the detection and endoscopic surgical resection of early GI cancers. He is a tireless advocate for early detection and prevention of these cancers and has directed public policy efforts to increase recognition of GI cancer risks among high-risk population. Let's welcome Dr. Juha Huang.
Thank you very much, Sally, for that kind introduction. It's a real pleasure to be here in Hong Kong. I was a visiting professor at the Chinese University of Hong Kong just before COVID hit, and so I had the pleasure of spending about a month here. And I want to thank the entire audience for spending their afternoon with us to learn about the cancers and the work that we're doing with care. So my topic is going to be on gastric cancer, and I labeled this an Asian cancer, and you'll soon see why. Just a quick raise of hands in the audience. How many people here know someone who's had stomach cancer? Go ahead and raise your hand. So it's a majority of this room. If I ask that question in the United States, it's an extreme minority of the room that would raise their hand. So there's a huge difference in who gets this cancer. So for those of you who aren't really familiar with this, gastric cancer, also known as stomach cancer, it begins when the cells in the stomach start to mutate and grow out of control. And if it's left undetected, it can spread to other parts of the body, also known as metastasis, and then that could ultimately lead to the patient's death. Fortunately, this is a very preventable cancer. It can be detected at early stages by endoscopy, which is a procedure that I do with gastroenterologists. And the problem is we're underutilizing this technology. So this heat map shows you why I'm calling this an Asian cancer. This cancer does not uniformly affect the world. It primarily affects Asians and especially East Asians. It is the fourth leading cause of cancer deaths worldwide. Over 1 million cases of gastric cancer are diagnosed each year. So this is a significant problem. You'll see in the United States, where we're at, it's a very low incidence country. So there's about a 6-fold difference in terms of incidence between the baseline United States and Asia. But the thing is that within the United States, we have, as Dr. Palaniappan mentioned, we have a 7% Asian population and others from other parts of the country that are parts of the world that are high risk that are essentially going pretty much ignored because the baseline population, primarily whites, aren't affected by this disease. So we're trying to change that. Within Hong Kong, gastric cancer is the number 6 leading cause of cancer deaths in Hong Kong. If you look at the United States, it's number 17. So it barely gets any attention, but there's a huge disparity on who gets it. So there are people that we know, there are groups of people who we know who are very, very high risk, but since it's in a minority or group, they're pretty much left ignored. And so we're trying to increase the awareness of this because these patients, we can intervene and we can prevent gastric cancer in these patients and we can save lives. And that's what us physicians do, is try to save lives. This is an example of another thing that Dr. Palaniappan mentioned is this concept of aggregation of data. So if you look at the incidence of gastric cancer in the United States and you look at all races, it's this value 10 per 100,000, which is low if you compare it to colon cancer, which is around 40 per 100,000. If you look at the general white population in the US, it's only about 9 per 100,000. And then if you look at Black Americans, it jumps to 14 per 100,000. And then if you look at all Asians and Pacific Islanders, it's up to 14.3 per 100,000. Still pretty low numbers, and so people go, what's the big deal that, it doesn't look like Asians really have that significant increased risk? It's because we aggregate data, and the problem in the U.S. still, in most parts of most parts of the U.S., we still aggregate Asians. We're just starting to break down ethnic distributions. And fortunately, California is leading these efforts, and so for several years, we've been reporting by subgroup ethnicities, and this is data out of California by a colleague of mine, Shalda Shah, who shows that Koreans in California have a 13 times higher risk of developing stomach cancer than the white population. And all East Asians, Chinese, Japanese, Southeast Asians, Vietnamese, all have a substantially higher risk of developing stomach cancer, and we're just not doing anything about it. What we can do things like primary prevention, secondary prevention screening, but these aren't covered by insurance companies because it's deemed that this is a rare cancer and we don't need to do any interventions for this. Primary prevention is pretty straightforward and it's something that we're trying to push. We know that H. pylori infection, it's a bacterial infection of the stomach that's very, very common in Asia. Back 10 years ago, probably had a prevalence of 80%. It's coming down now. So I think China has maybe a 60 to 70% prevalence of H. pylori. If we eradicate H. pylori, we can decrease gastric cancer by about 80%. It's thought that 80% of all gastric cancers are due to chronic H. pylori infection because it creates chronic inflammation that then over decades of infection leads to stomach cancer. There's a concept called secondary prevention in patients who we know who are at high risk, who've already had H. pylori infection, have already had chronic inflammation, are at increased risk, but haven't developed gastric cancer yet. We can then do an endoscopic examination and look for precancerous lesions and early cancers. This is completely not covered in the United States. In fact, insurance companies will deny coverage for this. So you can't say this patient's at high risk for gastric cancer, I'd like to do an endoscopy. They'll deny that. They'll say that's not covered. This is something that we're trying to address. Fortunately, in Asia, how many of you have had an upper endoscopy? How many have you had an endoscopic exam? See, almost it's because we know we get gastric cancer, right? It's part of an executive physical examination. Almost every year you get an endoscopy and you get a colonoscopy. It's because we know that there are risks. And the reason for doing that is to try and, this is endoscopy, this is an early gastric cancer in the stomach. Historically, this person would have to have their stomach taken out. So surgically, they would have to take their stomach out. But we now are able to do this endoscopic surgical procedure where we're able to preserve the entire stomach. And I apologize for the blood. Hopefully it won't make you queasy. But we're doing a super minimally invasive surgery through a scope where we're able to precisely cut out the cancer and allow the patient to continue to have their stomach and really function normally. It increases their quality of life, and we've done many, many studies. A lot of the studies done in Asia showing that there is an equivalent survival benefit, the same rate of recurrence compared to a severe, life-changing stomach removal. So this really has revolutionized the field. This is the lesions that's taken out. It's about 7 centimeters in size, and this patient is cured of their cancer. In order to find that though, you have to do screening because early gastric cancers are completely asymptomatic. They have no symptoms whatsoever. As soon as you develop symptoms, it's too late. That cancer has already progressed. So in Korea, they started a national screening program in the early 2000s, and you can see that with the acceptance of a national screening program, their percentage of early gastric cancer diagnosis, these are the curable cancers, has gone up to 73%. In the United States, we have no screening program whatsoever. We do what's called opportunistic identification of these lesions. So they're undergoing endoscopy for some completely different reason, and they're just lucky that they got their lesions found. So we're down at 24% of early gastric cancers in the United States. And why that matters is if you diagnose it early, you have a much better survival. So Japan and Korea have 5-year survivals that are close to 70% for all gastric cancers. Whereas the United States, if you're diagnosed with gastric cancer, your likelihood of being alive 5 years later is only about 25 to 27%. Okay, so it's completely unacceptable because this is a very treatable, preventable cancer. And you know, it's been frustrating because we in the United States, we just kind of, on a national level, don't address this because it primarily affects Asians and immigrants. And so we're trying to change things. We don't fully understand how gastric cancer develops, and what we're trying to do is better identify molecular markers that will really predict who is going to go on to gastric cancer. So we have something called the Stanford Gastric Precancerous Lesion Study that we enroll patients who have the changes in their stomach. We follow them with endoscopy every couple years. We take biopsies, we take blood, and we do molecular and genetic analysis on these things to try and find markers that are going to be specific. And a majority of these patients that are in our study are Asians, are primarily East Asians. And I'm going to just touch on one thing, and Dr. Polynapin mentioned this about the National Cancer Center, U.S. National Cancer Center funding. Right now, in 2020, they only spent $10.6 million on gastric cancer research, which is 0.16% of the NCI budget. And remember, Dr. Polynapin mentioned that the whole NIH budget, Asian research is 0.17, and so this is a subset of that because the NCI is a part of the NIH. So it's embarrassing low levels of funding for research, and it's the least funded cancer out of the NIH. And so why does it matter? Again, Dr. Palaniappan mentioned that the U.S. funds about 50% of the global research. You know, the U.S. funds 44% of global medical research. If you look at U.S. and Europe combined, they fund 77% of global medical research. The vast majority of that population are white. And so it doesn't apply, a lot of these things don't apply to us. There's less than 22% of medical research is funded by Asian countries. And so we have a lot of opportunity. That's why CARE exists. We're trying to change this. We need to work towards, I know one of the themes has been precision health. We need to work towards precision health for Asians. And there's a concept of health equality and health equity. And this is a really important thing everyone thinks that they want to be treated equally, right? Equality sounds great, but when you're a patient, you don't want to be treated just like any other white person because your genetics are different, right? And so what you want is equity. Equity is actually precision, right? If you look at equality, it takes everybody, lumps everything together, and we're going to treat you just the same way, right? Whereas equity it's like what Dr. Young was talking about. You're looking at specific risks, and you're targeting each individual as to what the risks are, and you're tailoring therapy to them. And so that's really what we need to try and achieve is health equity or health precision. And in the U.S., we call this disparity. I know some people don't like that, terminology. It makes us look like we're, begging or something like that. But that's what it is. There's a disparity. There's an unfair disparity in terms of, what we are addressing. And so there's a big health policy initiative. We have several partners, academic partners, private partners, the World Health Organization, Korean and Japanese hospitals. We're working on growing these collaborations internationally to increase awareness of this and to improve the funding. So in conclusion, gastric cancer, super common here in East Asia. 4th leading cause of cancer deaths worldwide, 6th leading cause of cancer deaths in Hong Kong. We can prevent it by treating H. pylori early on, and it's curable if we diagnose it at an early stage, and you don't have to have surgery. We can resect it endoscopically. But more research funding is needed for gastric cancer to improve outcomes worldwide, especially in East Asia. So thank you for that. Thank you for paying attention. And we'll move on to the final talk. I'd like to introduce Dr. Gloria Kim. She is a clinical associate professor of medicine and cardiovascular medicine. She's the medical director of the International Medical Services and the director of educational programs within CARE. She focuses on international medicine and is based here in Hong Kong for more than the past 20 years. She serves as a consultant and chief of internal medicine at the Hong Kong Adventist Hospital and was involved in teaching at both the University of Hong Kong and the Chinese University of Hong Kong. She's the chair of the Chi Pao Foundation in the U.S. and is a trustee of the Chi Pao Foundation of Hong Kong. So please welcome Dr. Gloria Kim.
Well, thank you for that really warm welcome, and I have to say it is wonderful to be back in Hong Kong. This is a place that I will always consider home, and it's a place that I loved very much. I'm also quite humbled to share the podium with my esteemed colleagues and leader. I feel that my role as the medical director and as of the International Medical Service and educational programs for CARE is to leverage the best that Stanford has to basically use everything that we have learned to heal humanity, one patient at a time, wherever they are. Through the generosity of the Chili Pao Foundation here in Hong Kong and the U.S., we have established educational programs that will link to Asian health. Okay, now. So at CARE, these programs focus on undergraduate and early graduate students and include the CARE Scholars Program. This is, as Latha had described earlier, a very intense online program focused on reaching students globally to teach them how to analyze big data and to answer questions about the health of Asians. We also use the program to teach students about team science, how to work collaboratively, and how to develop leadership skills. These are all really important to launch successful careers in healthcare. The CARE Scholars Program has actually become a very important source of information about Asian health. Since its inception in 2020, the CARE Scholars have published 18 papers, 10 abstracts. They've presented at 28 national conferences and 7 regional conferences. And we're talking about some students who are barely out of high school. This is an incredible achievement, not only for a program that is this young, but also among scholars who are so young. We also partnered here in Hong Kong, and this is something that's really close to my heart. We provided an opportunity for an outstanding medical student from Hong Kong U to spend a research year with us at Stanford. The most recent, Audrey, was just phenomenal. She was an outstanding ambassador for Hong Kong at Stanford, and she worked in the lab of Dr. Alan Cheng, who, by the way, was born in Hong Kong, and studied the mechanisms of hearing loss. She was a phenomenal student, and actually, I went to her last presentation, and people were crying. They were sad to see her go. She's now back at Hong Kong U. I saw her 2 nights ago. She is continuing her work with Dr. Cheng's lab, and so in a sense, she's become an ambassador for Stanford at Hong Kong U. And we think that she will go on to do fantastic things, and all of her mentors at Stanford, as well as in Hong Kong, have every reason to be proud of her. We also promote, what did I do wrong here? Oh, we also promote traffic the other way. We have provided an opportunity for 2 medical students at Stanford to spend a year at Chinese University to gain a Master's of Public Health, and also to learn what it's like to be an Asian in Asia versus an Asian in North America. Our first 2 students, Ada Song and Vivian Liu, have described their experience as transformative. And I just had a dinner last night with 2 of their mentors, and they told me that these ladies have really left a mark on the program in Hong Kong, saying that they uplifted the experience of their fellow students as well as their mentors. I also just heard that Ada, her master's thesis, was chosen to be presented at an international meeting. And this is a first for Chinese U and a reason for everyone to be proud. We also try, through CARE and through our global faculty, to offer opportunities in Asia on an ad hoc basis. One example of this would be one of the CARE Team Science Fellows, Tina Cheng, who actually is now a PhD student at Duke, is going to be participating at Chinese University on a study that is looking at equity in healthcare amongst populations in Hong Kong. Her mentor, Dr. Roger Chung, and she won an International Mobility for Partnership and Collaboration Award for this work. Tina also won just recently the Duke Chancellor's Award for Outstanding Research for an international student. Tina told me that she credits CARE for gaining the skills and the ability to do this kind of work and for opening these doors for her. In IMS, our programs focus mainly on on postgraduate and early career scholars, as well as established healthcare leaders. We have participated in live and virtual symposia. Latha told you about the one that we did in association with CARE on evidence-based Asian traditional medicine. We were in Beijing to talk about lung cancer, and just last night, or yesterday, we had the symposium on clinical neuroscience. These are also attended now by Zoom, so our audience can be quite large, and it's quite exciting to be involved in work like this. I want to tell you a little bit about the Chile POW Observership Program. Through the generous funding of the Chile POW Foundation in International Medical Services, we are recruiting identified future leaders in our strategic peer institutions throughout Asia to come to Stanford to observe our best practices. An example of it, we've included scholars from, for example, First Affiliated Hospital in Zhejiang, Peking University Medical Center, the Peking University Cancer Center, the Children's Hospital of Fudan. This upcoming year, we're hoping to recruit students from Chinese, or scholars or leaders from Chinese U and Hong Kong U. And what these young leaders do is they take what they see us doing at Stanford and share it with their home base. So an example of that might be in 2018, we had a young specialist in breast cancer. She had just finished her fellowship, but we could tell during the interview process that she was really going to be something. And so she worked for 3 months under the mentorship of Dr. Fred Durbis, one of our breast surgeons. And she went back to her home base, and she is now the vice chairman of the breast surgery unit and the vice president of the breast youth group for Zhejiang Medical Center. So we believe she is transforming breast care in China, or at least in Zhejiang, and that's really fabulous. I want you to know that it's not a one-way street either. We learn a lot from these scholars. So for example, when COVID first happened, I mean, we didn't know what was going on. We didn't know what was going to happen. So we reached out to one of our former fellows, observers, and Dr. Bao was the head of the ICU at Zhejiang University. So he joined our faculty on a Zoom call and told him the unfiltered story. What was really happening? What were the numbers like? How bad was it going to get? What seemed to work? What didn't? And it was really a great kind of heads up, get ready guys, this is really happening. And what was really, really touching is when he heard from us that initially our faculty and staff were having a lot of trouble securing protective gear. Remember the N95 masks? He personally sent over 200 N95 masks from his own stash to protect his former mentor, Dr. Arthur Sung. Remember when it came? And his fellow colleagues. And it was just such a natural outpouring of love and collegiality that was really, really touching. So what I want to say is that it's a two-way street. With our international scholars and colleagues, we teach, but we also learn. And together we serve. So you've just heard about the science that has put Stanford at the leading edge of healthcare. But how do patients actually access Stanford's cutting edge healthcare? Well, IMS. IMS can be a very useful and important portal of entry to the healthcare system. Now, navigating a healthcare system anywhere is hard, or can be hard. It's even worse if it's from a distance and you don't feel good. So what I love about my job is that I get to work with really fantastic colleagues, Dr. Young, Dr. Shang Chen, another medical director, and all of the navigators, Christina Lee, and we're just a team that has the same spirit of wanting to be part of the solution, trying to be helpful, and we are absolutely 100% committed to providing high-quality care and service to our international patients and our referring physicians. How do we do this? Well, when you contact IMS, we can provide information about Stanford Medicine. Yes, you could go to a web page, but sometimes when someone tells you, it's a little bit easier. We identify a physician or a team of physicians to address your problem. We help schedule appointments, not just the first one, but follow-up ones. We can coordinate cost estimates and billing arrangements. I know this is a frustrating exercise for many people, myself included. We can facilitate communications with your own doctors and your family members. We can provide translation services in all kinds of languages. It's really unbelievable. And we can assist with extended housing and transportation needs. And one thing I would like to say is that when you're a patient at IMS, you end up being part of our family. And we have been in contact, and this is part of the joy we stay in contact with most of our patients, and it's just really great to see how well they do. And sometimes when they don't do well, we mourn them along with the families. We also know that it's not always so easy just to hop on a plane and come to Stanford. It's not a reasonable thing to do in all cases, and in that situation, a second opinion might be the way to go. So for some conditions, in some specialties, a remote second opinion is possible. So how does this work? Well, we help you collect your medical records. A Stanford expert will review those records. A written report is sent to the patient as well as a local referring physician, and there's an opportunity to discuss any questions that might arise. And then sometimes the decision is, well, you know, there's no reason for you to come to Stanford. You are getting super good care where you are. We'd love to see you, but you know, it's a long distance, and sometimes that reassurance is what the patient needs, and that's great. Other times we might have something to offer that's different or better, or you'll find that you like the person that's on the phone, or you'll just want to come, then IMS will help you do that. In any way, whether you come or you don't, we're happy to try to help you get the best care, world-class care, wherever you are. These are our contact details, thank you, and we just love to hear from you.